Okay, hello and welcome to all our attendees. Thanks for joining us today. Let's get started. So thanks for attending this webinar. This is Leading to Recovery, Planning Priorities for Healthcare Organizations Post-COVID-19. Today we will discuss critical next steps for healthcare leaders in the wake of this crisis. I'm Lauren Duff and I'll be moderating this discussion. I'm a current student at the Healthcare Administration MBA program at the CU Denver Business School and the co-president of the Health Administration Student Organization. This presentation is produced by the Health Administration Student Organization at CU Denver. We represent the interests of students in the graduate health administration programs, and we regularly provide networking and professional development opportunities. We're pleased to partner in producing this virtual event with the Colorado Association of Healthcare Executives, or CAHE, our state chapter of the American College of Healthcare Executives. I'm sharing this message on their behalf. CAHE is happy to partner with CU on this very timely and relevant topic. Our collective goal is to support healthcare practitioners and students through these unprecedented times. We are committed to staying connected as much as we can, and we are very thankful that we have technology to support us. The Health Administration Student Organization also thanks Guidehouse and the Business School Alliance for Health Management for promoting this webinar. We're looking forward to engaging with our attendees' questions today, and we'll respond to as many as we can. We'll start the Q&A portion with a few selected questions submitted during registration. If you have further questions for our speakers during the session today, just submit those in the question submission area on the right side of your screen, and that's that purple button where you can submit a question. So joining us today are three healthcare industry experts who have graciously offered their time to share their insight today. So the first one we have is Dr. Rulon Stacey. He's an internationally known speaker and leader in the healthcare industry. He's served as CEO of multiple healthcare systems, chair of the American College of Healthcare Executives, and chair of the Malcolm Baldrige National Quality Award Board of Overseers. He's the current chair of the CEO Circle of the International Hospital Federation and has received a number of awards for his efforts to improve the quality of healthcare. He was twice named by Modern Healthcare as one of the 100 most influential people in healthcare. Dr. Stacey is currently the program director for the graduate programs in health administration at CU Denver, and he's a part-time partner of the Health Strategy Business Unit at Guidehouse. He provides expertise in the areas of organizational transformation, strategy development, and performance leadership. He has a BS in economics and an MHA from Brigham Young University, as well as a PhD in public administration from CU Denver. Dr. Jiban Khuntia is Assistant Professor of Information Systems and Program Director of the PhD in Computer Science and Information Systems program at the CU Denver Business School. He received his PhD from the Robert H. Smith School of Business, University of Maryland. Dr. Khuntia's research is in the areas of health information technology and service innovation. His work has appeared in journals including Production and Operations Management, Journal of Management Information Systems, Decision Science, Decision Support Systems, Communications of the Association for Information Systems, and others. Dr. Khuntia has also a decade of professional and consulting experience in supercomputing, the IT industry, and government organizations. Rich Bajner is a partner at Guidehouse and leads the value transformation segment of the healthcare practice. He works with leading payers and providers in developing their integrated network, product, and pricing strategies, including the design and implementation of accountable care organizations and bundled payments. His expertise spans more than a dozen of the largest ACOs and over 200 facilities. Mr. Bajner also advises providers, commercial payers, and state Medicaid agencies on designing and implementing payment models that align incentives to achieve improvements in care delivery. He was recently recognized by Consulting Magazine as a healthcare industry rising star of the profession for his ability to navigate through exceptional change as the marketplace redefines value in healthcare. So thank you all for joining us today. And with that, we're ready to get started with the presentation. So we're going to start, and I'm going to hand it over to Rulon for the next segment.
Thank you, Lauren, and thanks everybody for joining us. I wanted to also thank the student organization for organizing this webinar today. A few weeks ago, Dr. Khuntia and I authored an op-ed that appeared in Modern Healthcare, and that is the genesis of our comments today. The student organization on their own took the leadership to create this webinar and to organize everything associated with. We appreciate that. As we started to prepare for the comments today, we invited Rich Bajner to join us because he has so much background in disaster preparedness. I should note and think it appropriate to note that while I'm a part-time partner at Guidehouse, I have no financial incentive of Rich being here and participating in this webinar today. So with that caveat, I'll turn the time over to Rich to begin to talk a little bit about how to take full advantage of the disaster funding as we theorized in our op-ed a few weeks ago. Rich?
Great, thank you, Rulon, for the opportunity to join and to be with everybody today. Obviously, over the last several months, our nation has been facing an unprecedented degree of change in responding to the COVID pandemic. And on the front lines of the change are all of our provider clients serving and protecting their communities. What we want to talk about a little bit today is how our providers are facing these challenges in the many communities around the country, either by one, preparing for COVID to enter their community and come into the doorways of their local healthcare institutions, or two, actively treating and attempting to cure patients that have been diagnosed with COVID. The goal of our next 5 to 7 minutes will be to share a little bit about the funding that is made available to healthcare organizations, specifically public healthcare organizations and private not-for-profit organizations, in obtaining necessary funding to cover the cost of responding to the pandemic, and in some instances covering lost revenues that clients are experiencing. Our clients are looking through this pandemic to better understand the strategic, operational, and financial impacts of COVID. And I think it took a little while for providers to understand, and policymakers now to understand, the degree of financial challenge that healthcare organizations would be feeling as a result of the pandemic. And increasingly, we're starting to talk to our clients about the fact that these financial challenges aren't only going to last while we're fighting COVID, but they're going to be longer lasting as the market has dramatically changed through the pandemic. Specifically referencing the fact that just earlier today, another 4 million plus Americans were announced to have been unemployed, and we're up to about 25 million over the last weeks. So as 25 million people are unemployed, that changes insurance status, that changes demand patterns, and that can influence and impact healthcare organizations. So as you can see on this slide here, significant operational impacts of treating patients, but also in preparing organizations to care for their staff and to start to mobilize around how to reopen their organizations after COVID starts to we start to flatten the curve, as we've all learned our terminology. Financial impact has been pretty significant. We'll talk about that today, and then certainly the strategic impact is ongoing and an emerging question, especially as hopefully the industry adopts telehealth and digital technologies as part of their future. So on the next slide, I think that we are all familiar with where many of the hotspots are, but as you can see from this graphic, outside of the hotspots of the Northeast, of New Orleans, of Detroit, Chicago, and California, COVID has really impacted organizations and impacted states all over the country. I think what is often missing in the conversation is that hospitals, whether they're in a hot zone or not, are prepared to serve their communities and prepared to tackle this virus, and therefore are shutting down much of their organization to create capacity should COVID enter their doorsteps. Many governors around the country have asked healthcare organizations to suspend elective surgeries, for example, to provide shelter at home orders, which is reducing physician visits, and that's having a significant toll on healthcare organizations. This slide is intended just to show an example. 60% reduction in physician visits, a 55% decline in physician revenue. That's just the tip of what provider organizations are feeling. We've had the opportunity, we're serving about 350 hospitals right now through the pandemic in their response, and have had the ability to talk to more than 1,000 hospitals in the last 2 weeks. And the average provider organization is seeing order of magnitude 30 to 40 to 50% revenue reduction as they've closed their hospitals to create capacity for serving the community should the pandemic arrive to their local towns. So when you start to talk about 40-50% reductions in revenue, in addition to higher expenses as they're trying to obtain necessary PPE, as they're standing up new capacity, ICU capacity, et cetera, provider organizations are struggling financially. We're helping our clients think through a framework to think through this. I'm not going to spend a lot of time on this slide. I'm going to introduce the slide and then talk about how clients are recovering. So the response is ongoing, and that's active right now, and that's been active for the last 90 days in responding to the pandemic. Phase 2 is then how to recover through the pandemic. How do you address your short-term cash pressures and liquidity concerns to make sure you can keep your doors open, that make sure you have the right supplies in response to being ready to treat patients. Third is restoration or restore. How do we get back on our feet on the back end of the pandemic and making sure that our organization is as healthy as it was before the pandemic? And then 4 is how do organizations reimagine a future that's much more digitally enabled, ambulatory focused, and revenue streams may look very different operating models. So what I want to do today is cover the recovery and the solutions that are available, and I'll do that over the next 2, 3, 4 minutes. The next slide. There's been 3 different CARES Act pieces of legislation. The biggest one that passed a couple of weeks ago provided $2 trillion of funding to our country, of which $153 billion is funded towards public health, and $100 billion has been towards hospitals, $20 billion towards veterans care, 16 for medicine and supply. Within that $100 billion that's organized for hospitals, there is, on the next slide, funding that is breaking out between what's available through FEMA, the Federal Emergency Management Association, and funding that's being available through CARES Act or other. FEMA, all the way to the left, once the president declared a national emergency, FEMA became the entity responsible for responding to that national emergency. As such, as providers are spending money to prepare for the pandemic or to respond to active cases of COVID, FEMA is responsible for reimbursing providers for eligible costs that they are experiencing that they would not have otherwise spent but for responding to COVID. So as our provider clients are spending money in preparation for or responding to COVID, there's a process by which they can request a public assistance grant that they do not have to pay back, that they can submit appropriate documentation through what's called a Category B project worksheet, and receive funding for these eligible costs. This is a process that's run state by state, so providers have to work with their state emergency management association to submit this paperwork and get approval for their quote-unquote project, and then they can draw down funding for their eligible costs. Of note, currently, the feds have assigned or agreed to reimburse 75% of these eligible costs, plus a 5% management fee on top of that. So providers are covering 75 to 80% of their costs that they're bearing through the pandemic. Of note, certain states are increasing that. The state of Washington just announced that they will cover the additional 25%. So this FEMA bucket of money, federal bucket of money, is being made available to cover eligible costs, but that doesn't help providers through their lost revenues. The CARES Act is intended to help stabilize the healthcare industry, and they've already distributed $30 billion of the first $100 billion that's in column 2 to provider organizations. Just yesterday, they announced another $40 to $50 billion of funding to hotspots, to rural healthcare, and $20 billion of that to the rest of the industry to, again, stabilize healthcare organizations. Currently, going through legislation is another $75 billion dedicated to hospital and healthcare organizations. So the funding stream will be from the federal government, in addition to FEMA, will be $175 billion to stabilize the healthcare industry that can be spent on eligible cost and or lost revenues. I'm not going to get into too much of the details to the right on what Medicare and Medicaid are doing beyond that. You can see that here, but there's a lot of really detailed activities going on behind that around covering COVID expenses at a 20% higher pay, suspending sequestration models, et cetera. So states and Medicare, Medicaid specifically, beyond HHS, are also enacting policies to stabilize a provider segment. I'm going to wrap up here just momentarily, and I love to organize this slide because the commercial market is responding too. So we have FEMA here, we have HHS and CMS and Medicaid and state leaders, but also health plans are stepping up, and we're starting to see an increasing number of health plans working with providers to stabilize cash flow in the current environment. Of note, though, I get a question a lot is, why aren't health plans doing more? Well, the easy answer is they're under their revenues are challenged as well, especially commercial plans. As there's 25 or 30 million commercial members moving to Medicaid, health plans are losing that revenue as the members move from being a commercial member to a Medicaid member. So maybe a little bit in closing is, and this is what I talk about here is in this slide, I'm not going to go through it, is just the shifting of commercial mix to Medicaid mix. So in closing is the federal government recognizes the degree of strain that provider organizations are in, and they've set up these methodologies through FEMA, through HHS, or other avenues to stabilize the healthcare industry. However, these entities have never had to respond to a national pandemic, so they're sort of writing the rules as we go and learning a little bit on the fly, changing rules on the fly. But hundreds, if not thousands, of organizations are already in flight seeking these reimbursements to cover, again, their eligible expenses and lost revenue. I want to hand it over to our next speaker, and we'll be available for questions on the back end of this. So let me pass the baton forward.
Jiban, I think you're up.
Okay. So hello, everybody. So what the piece that I was more interested to bring about is embracing digital health. Rulon and me actually wrote this article almost a month before, and I think I have seen maximum development in digital healthcare in the last 1 month than last decade or so. And when I'm saying that, we have seen hospitals and clinics and doctors jumping into telehealth, e-visits, and all these kind of what we call as digital front door to manage how to reach our patients, customers, and how to provide healthcare. So 2 points that was sort of a one way you can say a confession and a resolution for the healthcare industry when we wrote it 1 month before is let's improve the access through digital front door that may be using telemedicine, e-visits, virtual cares. The other point also we emphasize there, we should enable and improve the back-end health IT infrastructure to align with these developments that came out. Last month, as I said, probably we have seen, and somewhere I came across this, let's say jokingly, people are saying that earlier CFOs, CIOs, CTOs, and CMOs used to champion digital health. Now the COVID-19 situation is championing and leading the digital health transformation, and that's true. So going forward, and many people are asking, Is it a permanent transformation? Is it going to be the way it is? How to be part of this movement now? I think a couple of suggestions that I can give. Leapfrog. This is actually the only opportunity, or one of the greatest opportunity that we have got to leapfrog to all those digital health concepts that healthcare industry broadly has missed. And we see banking and retail and all these have moved so much towards customer care, reaching to patients. And we are still calling patients to come to the institutionalized walls of healthcare, that too whenever they are completely sick. So can we extend or change the model to reach the patients proactively and give a high touch at their end? I think this is the time to think out of the box for the modalities. The modalities can be portals, discussion forums, intermediary platforms, different alerts, apps that is available at the patient end, fit for purpose health apps. Also, one of the things when we are doing this, to keep in mind that when we are doing this, the high touch point of care should not be forgotten. I just summarize that, yes, we need to move fast in this, and already organizations are doing that. There is going to be a bunch of regulatory developments. Telemedicine reimbursements is going to be changing. The barriers towards regulation is going to be reduced more and more, and the value potential of telemedicine will be established, and people are going to be connecting more. So accordingly, we need to align and shift the care, cost, and revenue model to this new approach. That sounds quite easy, but what needs to be done is very difficult paths to follow. And I think being sensitive to all these, as well as following the policy model and convincing the policymakers to do that, is one of the things probably that is the key terms in this hour. I would pause here and come back again to answer some questions. Over to Rulon.
Thank you, Jiban. I should note that just this morning, Jiban and I, with some other faculty members of the University of Colorado, were on a call with the International Hospital Federation, and we noted that everything he just talked about are issues that hospitals around the world are experiencing, and the issues that we're trying to address are truly global in their nature. The third thing that Dr. Khuntia and I argued in our op-ed was that the first being that organizations needed to take full advantage of the disaster recovery initiatives that Rich talked about, that telemedicine would become more influential in the future than ever before, but that we couldn't, the third thing was we couldn't afford the luxury of operating inefficiencies going forward. We had to maintain those efficiencies. The first thing I would argue with that, relative to that, is that we listened to what Rich and Jiban said. Disaster funding and telemedicine development will be critical in maximizing revenue going forward. We've got to take full advantage of everything, every option that is available to us, and that is including digital front door, telemedicine development. The world became comfortable with telemedicine in the last month. And in my career, we've been waiting and waiting and waiting, and it happened in a month, and it will never go back, ever. And so that's the opportunity that I think we can take from this going forward. So the revenue associated with that, we have to make sure that we take advantage of that. But we also have to understand that the years of living off of our non-operating income relative to our foundations or other investment revenue also died in the last month. We all know organizations, and many on this call may be in an organization that has supplemented their operations with non-operating income. We're not going to have that luxury again, maybe for the rest of my career, but certainly for the foreseeable future. So that means that we are forced to find ways to become operationally effective. Rich and I actually did a study some time ago that that suggested that size in organizations didn't matter. I spent a good part of my career saying that if we got to 2 billion, then we would be okay, and if we got to 4 billion, then we would be okay. And what we found was that it wasn't if we got to 2 billion or 4 billion or 8 billion, it was discipline. And discipline is what mattered for organizations. And so for those of you in organizations that are 800 million, or those of you that are in organizations that are 10 billion, your future is going to be centered around your ability to become disciplined in your ability to control costs. You have to take full advantage of revenue, and we've offered some thoughts on how to do that today, but controlling costs is going to be more operationally critical in the future than it has been ever before, and it's been very, very important. In the article, we pointed out the Moody's report in August of 2018 that expressed some amount of distress that organizations in the prior 10 years had experienced growth in costs to exceed growth in revenue on a distressing level. And they argued that if we didn't get that in control, we wouldn't be successful. And that certainly is no less of an issue today. I do think we'll see more of another run at mergers and acquisitions in the future, because I think some organizations find themselves in a position where they just can't be successful now after the last month or two or three. But I don't think that we need to think that if we get to a certain plateau, if we get to 8 billion, we're going to be safe. If we get to 10 billion, we're going to be safe. You'll be safe when you have leadership discipline in your organization. And just Lauren mentioned earlier about my role as the chair of the Board of Overseers of the Malcolm Baldrige National Quality Award. The way to include all of these things we're talking about, the best criteria ever developed, I will argue, is the criteria of the Malcolm Baldrige National Quality Award. It is detailed, and it takes a long time to get engaged and to get an organization thinking the way the way of process literacy. But organizations that do are prepared for what happened in the last 2 months more than those that are not. So I would argue that that is a criteria that you can take full advantage of, and I would encourage you to look at that. It won't help you this year, but it will help you in the next 3 to 5 years as you prepare for the future, and it will keep you protected for the future. I received some feedback in preparation for this webinar from some faculty members. Most particularly Dr. Blair Gifford sent me a link to the CMS website, which I think provides great information for us on how to prepare for phase 2, what we're calling COVID+1, the day after COVID. What do we do to get ready? And I would refer you, since receiving that email from him, I have gone through that website in some detail and would recommend it to you as some opportunities for your organization to understand what is available and what isn't available going forward. And so with that, we're at the bottom of the hour. I think we're maybe even a little bit past Lauren. I'll turn it back to Lauren for some questions and answers of our panel.
Okay, thank you all so much. That was incredibly informative. So just to kind of transition, we do have a few prepared questions that were submitted by registrants. So we're going to take a look at those first, and then we're going to transition to questions that have been submitted during this session. So the first question we have prepared for you, I'm going to put primarily to Jiban and Rich, and it's around how health systems are looking into the FCC's grant to support the telehealth shift. So if either of you or both of you could speak to what that has looked like, particularly in pursuing that.
Rich, you want to go first?
Sure. I can speak on behalf of our clients. Almost all of our clients are interested in exploring opportunities to seek funding to enable a shift to telehealth or to digital capabilities. While most of our clients are multi-billion-dollar health systems, and the FCC grant only will award up to $1 million per organization, that $1 million doesn't go far for a multi-billion-dollar organization trying to stand up capabilities, but it does get them started. Therefore, I anticipate a significant number of applicants moving forward seeking this grant money because our provider clients recognize that the future will be more digitally enabled than the past.
Yeah, I think they just released for 6 health systems around USA who got the first level of grants. If we look at them, the way they are expanding, so there is this Hudson River Healthcare Grand Memorial, Grady Memorial Hospital, Mount Sinai. If we look at that, they are looking not only telehealth, but they're also bringing the mobile health, mHealth systems with that. Expanding the scope to multiple other things. So in other words, it's not only just using telemedicine for COVID, but they are talking of remote patient monitoring. They're talking of palliative care for patients, different high risk and vulnerable populations. For example, the Ochsner Clinic Foundation in New Orleans, which got the grant, some $1 million. They're talking of Louisiana and Mississippi to serve the vulnerable and high-risk populations. So if we slightly scan through the already awarded grants, we see there is a movement emerging, not only to use telehealth for or in the COVID context only, but also expand it to other avenues. And this is good because, and I'm also bleeding into the questions that how the future will look into. This is good because we have been seeing this cost inflation in healthcare quite significantly, and part of somewhere there has been criticisms that some 70–80% of what we do in healthcare in terms of visits, coordination, transactions probably can be offsetted to somewhere else and let the health systems only focus what we call as critically important. So, and even on the patient side, patients do not come to hospitals or clinics for normal treatments because that the inefficiencies associated with coordination, access, making a schedule and stuff like that. So telehealth is going to reduce the cost substantially. It may not happen right away. There may be a progression going on, and as much as telehealth is emerging as a critical service for providers and patients during this pandemic, but it's also going to remain and stay as a important solution in healthcare.
Okay. Thank you both so much for that response. The next one we wanted to move to is specifically what can rural healthcare organizations focus on to move toward normal operations, and how does that picture look different for them? And I think I'd primarily like to address that to Rulon.
Thanks, Lauren. So rural healthcare will be the greatest recipient of the new push toward telemedicine. I believe that one of the things that we've been working for as an industry is a push toward telemedicine and a push toward non-physician providers, physician assistants, nurse practitioners. Part of that is developing telemedicine options, and part of that is arguing to legislators we need to do to be able to get better access in rural medicine. And so the good and bad of what we've seen is that we need to take advantage of telemedicine, and that will increase these operations more than it ever has in the past. We need to keep pressure on legislators to make sure that we stay there. The problem is that part of what has happened has exposed rural healthcare and the cost structure of rural healthcare. I just don't know that we're going to see cost-based reimbursement indefinitely in rural healthcare. A month ago, I would have said we would. So I think that there is now a push to develop some of these tools that we've received, that we have now with telemedicine. Part of it is to find ways to keep our costs down. And for those who haven't looked at partnerships, there's probably an incentive to look for partnerships in the near future as well.
Okay, thank you. Okay, so our next question is, is it possible for hospitals to succeed in this environment where we're expanding capacity and we're going after value? And how do we bridge that gap and return to profitability? I'd like to address that to Rulon and Rich.
Rich, I'll let you go first.
I was going to say, I was going to let you take all the hard questions. So I think my perspective here is, as the market is changing, so too will the actors within the market need to change to be successful. And what I mean by that is, I think pretty quickly we're gonna find out that, at least for this first phase of COVID, and I know there's talk that this may be with us a while, or we might see second or third phases, that the system, we have the capacity to meet a lot of the demand for responding to COVID. So I think about this a little bit less from a perspective of capacity, at least for now, and more around how do providers and payers continue the momentum of creating a better health system going forward. And I think one of the key lessons that there is, if we want to go and find it and see it, is revenue predictability really matters to both payers and providers. And if there's one state that's making it through this pandemic better than the others, it's Maryland. And I'm not saying I'm an ambassador of their global budget model. They are the only state on a global budget model. I find few people outside of Maryland know about it. But what's happening is there's a payment model that is creating predictable revenues for providers, even when volumes are declining. So I've started to talk to my payer and provider clients about different ways of accomplishing the following goals. One, recurring consistent revenues. Two, continuing to create alignment between payers and providers around improving the quality of care. And three, continuing to stay focused on creating a better product that is digitally enabled that can reduce the cost of care over time. And our clients have been picking up that conversation, willing to have the conversation. The biggest risk I see with this is, as provider revenues are strained and as commercial health plan revenues are strained because of their loss of membership, as the commercial market goes from 165 million lives to 130 or 140 million lives, both will be starved for creating operating profits. And I'm scared that the negotiations between payers and providers will become more challenged and more turbulent over the next 12 to 24 months as both fight for every dollar possible. So I think we're going to have to look longer term and score progress on a value agenda longer term than over the next 12 to 18 months.
And I would add, Lauren, to that, I'll give a brief example. I was at a meeting last year that had several hundred people in that meeting, and there was a question that came from the audience in that meeting, and one of the executives of a hospital said, our volume is high, but we have no revenue. That we're full of patients, but we don't have the revenue to support that. And in my mind, I thought, where have you been for a decade? How is this a surprise to you? And what have you been doing? And there have been markets where we've had the latitude of delaying the inevitable, and I think this has sped up the inevitable. So I think that those organizations that have been preparing for this over the past decade will be better off than those that haven't. I don't know that there are some changes that are happening, but it's the speed of what's happening, not necessarily what is happening. And the cure for that is good leadership. And the best place to get good leadership is University of Colorado, Denver. Just saying.
Yes.
Yeah.
Hey, Rulon, and picking up on maybe one of your comments, I think it aligns with mine, but the naked eye may not make the connection. So allow me to make the connection, which is as commercial volumes go down, where do they go? They're going to go to Medicaid. Medicare Advantage is continuing to see a significant uptick in lives as Medicare fee-for-service transitions to Medicare Advantage. And oh, by the way, CMS announced good rate increases for Medicare Advantage plans. So there's increased money available in government programs, specifically around Medicare Advantage and Medicaid managed care. And that's where a lot of the shifting of value was occurring anyway, because of how the payers are reimbursed on a premium chassis from the government, and they're distributing those premiums in a lot of cases through shared risk contracts with the providers. So I anticipate that there's money, that the overall money available in Medicare and Medicaid can be conducive to value arrangements, even if the commercial market may be more challenged.
Wow, that's an incredible point. I think, so many organizations do rely on some of that cross-subsidization, and it's encouraging to think that will at least be, somewhat more viable even as commercial goes down. Okay, let's go to our next question. So how do you anticipate hospital leadership structures and governance changing as a result of COVID-19? We thought this was a really interesting question. We wouldn't have thought of otherwise. And I'd like to direct it to Rulon on the kind of administrative structures piece, and then to Jiban as well on more of a data governance perspective as well.
Well, I have argued for several years that the greatest challenge that we have, one of the greatest challenges we have in healthcare is ineffective governance, and it's a hard thing for organizations to address, because it leaves administrators to go to their bosses and say you're not cutting it. But there are organizations, many organizations today, where governance board members are not trained. They don't have ongoing education. It's part of the reason why we have the variability in many of the organizations. I think that this will push us toward that end where I think it'll move that curve along. Governance is a passion of mine, and largely because it's been so ineffective in so many places and so effective in other places. And I think we have an opportunity to bridge that gap. I think that COVID-19 will again move that curve forward and force us to bridge that gap a little bit. And if you're in an organization, first of all, if you're in an organization with an elected board, that's bad governance. You can't work that way. If you're in an organization where your board members aren't regularly trained going to meetings, you got to fix that. And I can say that with people I don't know who are on the line. So, Jiban, I'll let you talk about the IT side.
Yeah, one of the things that has been realized in the last 1 month, we were not prepared as health systems. For a moment, I'll ignore the public health side. But when hospitals came rambling around what we need to be doing, that was concerning. And that actually created a lot of public outcry, and stopping these services and all those things didn't go well with the public. What it means at the back end, hospitals never, we call it in military terms, never modeled for missions like that. What would be a warlike kind of situation? And that brings back to the point that did hospitals not have the information? Yeah, they have enough information, and as widely been talked about, the whole concept of digitization has enabled hospitals to store large amounts of data and information, but they have not been able to derive enough knowledge, intelligence, preparedness using some of those things. So this is sort of an opportunity to go back, and I think most of the hospitals will look at and start building those intelligence analytical ways to look at, let's say, patient flow and volumes. What happens if we shut down particular wings? How we can still be alive or be running our systems even if we shut down ER and other things. Those kind of scenarios can be very well modeled. And that calls for this intelligence and analytical usage of information, calls for also one level of change that we have not seen yet, that is designing the existing systems to actually tackle the workflows. And somewhere somebody has asked a question in the question answer also, that what happens, these telehealth systems are not aligned to the existing systems, and that's true. Our electronic health records that hospitals are using now is not designed to care delivery. Most of the time it was designed to track and bill reimbursement models rather than providing optimal or any changes to the patient care. So probably this is time to look back to those blueprints and see what are those important workflows in terms of care, in terms of trials, in terms of patient evaluation, and how can we align the existing telehealth systems to those kind of things. So broadly, information technology, value proposition of IT and subsequent intelligence was not a boardroom talk so far for most health systems. Occasionally, yeah, for big systems it was. So I think the governance and leadership will bring it further over there. In each and healthcare entity and health system, we'll talk about that. Inter-organization wise, we are already seeing a lot of changes in terms of this whole white elephant in the room known as interoperability. We know that health systems don't talk to each other and they have issues. And we see that interoperability barrier sort of started melting now. Health information exchanges, for example, across Florida, New York, they have started loosening provider requirements to allow for easier provider access. So what it means that we can do it. We can really build an interoperable system going ahead, and those inter-organizational discussions will start moving on in terms of data governance and analysis. So I'm expecting a different kind of digital infrastructure and value proposition to be built in the next year or two post-COVID scenario around digital health, the whole concept of service delivery and interoperability and more communication and coordination across healthcare entities along with within the health systems as well.
Okay, thank you so much. I definitely hope that happens. Okay, we're going to skip straight to live Q&A for the remaining 5 to 10 minutes of our session. So the first one we'd like to pose to you, and I think this would be a great question likely for Rulon or Rich, and that is, do you see any risks for Medicaid rates to fall further as enrollments increase there?
Oh, that is so rich.
For those that study state budgets, one would easily recognize that the trend line that states are spending to care for Medicaid recipients is only increased substantially over the last 10 years. What most people won't recognize is that trend line has increased during an era of economic prosperity when the Medicaid population was the lowest. And at the same time, state budgets have continued to be largely in the red. Those three things don't correlate very well. And now that we're entering a period when a public health crisis is turning into a financial crisis and Medicaid enrollment will go up, the bleeding that state budgets have been facing is going to get worse, and states will have to respond in some way. Since Medicaid is one of the largest budget items, I would anticipate that they will look to cut cost in Medicaid in some way, either by reducing, changing eligibility standards, changing coverage standards, and/or potentially even looking at rates. However, since so many lives are in a Medicaid managed care program, states will have to balance cutting it too far and losing the carriers from leaving the states because they can't make any money. So it's going to be a delicate balancing act, and being a state budget officer is going to be an extremely tough job over the next several years.
Okay. Thank you so much. We do have another question, and it is, let's see, I'm going to read it first and then we can decide who can take the first crack at it. So for health systems that run hospital-based outpatient clinics, what are some strategies creating alternative revenue streams to replace facility-based fees? And, you know, a couple of ideas they put out there is remote patient monitoring, chronic care management, as a couple areas of focus. So again, what are some strategies to create alternative revenue streams to replace facility-based fees?
Jiban, do you have any thoughts about remote patient monitoring or other external monitoring like that from your perspectives?
So I think the question is asking whether do we have money or
can we generate money
on more of a telemedicine basis, I believe.
Yeah, telemedicine, I mean, there is already momentum that telehealth reimbursement has to be done. So CMS is coming forward, and I believe that will percolate down to the payers reimbursement as more and more providers adopt it. Telehealth market is growing, and there is no doubt about that. Couple of vendors, I'm just forgetting their names, but couple of vendors have seen exponential growth who have been providing services to some of these companies. They're showing exponential Teladoc, TELADOC, that provides virtual healthcare in more than 130 countries. It is facing now 20,000 request visits per day. That's more than what Zoom and other companies are facing. So certainly reimbursement models which will change. Broadly, I would say this is a time to reinvent the business models that healthcare has been facing, and move some of the reimbursement models to things like obviously remote care and telehealth based models, as well as things like providing a platform where patients and providers can come and talk, and existing patients can inform. None of those are being reimbursed so far. So I believe this is it might take a little bit of time for everybody to realize this is the thing, but the realization has started.
Okay. Thank you so much. So I think we have time for one more question, and then we will start to wrap up here. So the question is, with the devastating impact on provider P&Ls and balance sheets, what do you anticipate in provider rate increases? In Colorado, as you're well aware, there are already significant efforts to receive better value from providers.
Well, I'll let the other two offer their opinions on this in closing. I have long thought that there's nobody in Washington, D.C. and nobody in your state capital who stays up at night thinking about how to get you more money. I think what they think is how to pay you less. In Colorado, that's particularly true. In Colorado, there's nobody at the state capital who thinks that the providers in Colorado are underpaid. So I think that long term, it goes back to my comments about making sure you maximize the revenue you can right now in the two areas that Jiban and Rich talked about. but find ways to keep your costs under control. Lobby hard, become engaged with your state associations, but harbor no illusions about how much money you will or will not get in the near future from reimbursement sources. Richard Jiban.
To me, this might open another avenue for health systems, payers and providers, is to commoditizing this whole concept. Is it possible that for a simple sneeze, I am ready to pay $20, or for that hangover on Monday morning, I pay $30 because I want aspirin to be sure? Those kind of models, I mean, Health Doc and Doc Jock, all these models are evolving. So commoditization of the model might bring some additional revenue streams that we have not seen yet. You can call it more number of services with a smaller revenue streams per service. So the time to reinvent the business models.
Hey, Lauren, this question is a timely question. If you study healthcare history, you'll notice that the last two times that the Medicare solvency decreased to below 8 years, major policy changes were enacted. In 1998 was the Balanced Budget Act. In 2011-12 was ACA. Today, as we speak together, it's 2020, and Medicare solvency is predicted to be good through 2026. Today, MedPAC announced that that 2026 number did not take into consideration COVID, and that if the COVID impact is maintained, solvency would be guaranteed only through 2023. We haven't seen an environment when Medicare solvency was so close to us in the future. So there are going to be some pretty significant pressures. I already hit on the state pressures around state budgets. There are some pretty significant pressures at the federal level around Medicare solvency that will create barriers to rate increases. That being said, nobody will allow an environment where access to care is significantly compromised. Therefore, it'll be a balancing act. But I don't see the current environment or the environment for the future one which rate increases will be easy to obtain. Therefore, I totally agree with our panel that changing of business models to a more consumer-focused model, to a differentiated set of products, is going to be important for health systems to ensure future success.
And that's where I would also point out that that's why our health administration, our digital health, everything sitting in CU Denver Business School, and our students who are graduating, they would be championing these and trying to see how these business models can be effective. So those of you who are on the audience side and are looking for hiring, we have ready-made people who are already thinking about this. So give us a call.
I wholeheartedly agree. And thanks for the shout out. Well, you all have been a terrific panel. Thanks again to our speakers for offering your time, offering your insight. It's been an incredibly thoughtful discussion with all of you, and thank you also to the attendees for submitting such thoughtful questions both in advance and during the discussion. That was just such a rich set of things to discuss. So just to wrap up, a few more things. We did want to share out contact information for our three speakers. They have welcomed your questions or comments if you have any that that arise after the event or during that you weren't able to get answered. We also have a contact for the Health Administration Student Organization if you'd like to reach us specifically. And CAHE also invites you to connect with them if you have additional requests or ideas for how they can support you during this time. So thank you again to our speakers, attendees, and everyone who contributed to this event. Thanks for joining us today. And with that, we're going to wrap up. Take care, everyone. Have a great day.
Thank you.